I thought I'd just do a very quick video on urinary tract infections and address a lot of concerns concerning UTIs. First of all, there's a big rumor that, I don't know if it's a rumor, but people assume that you can actually get a UTI from a toilet seat. I want to actually get your input over that because medically I don't believe that that's 100% true. There is a possibility, but it is very rare. So drop your comments below, grab a piece of paper, and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at urinary tract infections, also referred to as UTIs. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. Grab your piece of paper, grab your pen, and let's go. In view of the new style of the lectures on my channel, we usually start up with the warm-up question. So you may actually write down your answers or scream your answers at the screen. I will give you the answers at the end. So the typical features of lower urinary tract infections, UTIs, include A, rigors, loin pain, and renal impairment. B, suprapubic pain, dysuria, and hematuria. C, progression to acute pyelonephritis if untreated. D, midstream urine culture producing Escherichia coli greater than, this should be 10 to the power 5 per mil. And E, the drug of choice for the majority is ciprofloxacin. So what exactly is a UTI? Before we actually go into UTIs, let's divide the urinary system or the genital tract into pretty much two halves. There's what is referred to as the lower urinary system, and there's the upper urinary system, upper urinary tract. So the lower urinary tract, just think everything below the bladder. So the bladder itself, the urethra. Then the upper urinary tract is pretty much everything above the bladder. So you have the kidneys, you have the ureters, and to some extent even the prostate is considered as an upper urinary tract system, because if it gets infected, it's considered as an upper urinary tract infection by some authors. So we can actually divide UTIs broadly into two main groups. Remember that this is an acute infection of the urinary tract, and this is going to be defined as either lower urinary tract infection, where you have a urethritis or a cystitis, meaning it's affecting the urethra or the bladder. You may have an upper urinary tract infection, which could be an acute pyelonephritis, a prostatitis, an intrarenal, sometimes even a perinephric abscess. Now remember, for you to say that someone has a UTI, you have to actually have pathogenic microorganisms that are detected in the urine, in the urethra, in the bladder, in the kidney, or even the prostate. And a big indication about this is, remember that the lower urinary tract is not completely sterile. So it means that when we're actually collecting our samples for investigations, we have to collect them in a special way. So remember that in most instances, the definition of a UTI is going to be defined as more than 10 to the power 5 organisms per mil from a properly collected midstream clean catch urine sample. And this is going to be indicating that someone has an infection, of course, if they have symptoms. If they are symptomatic, we can even use a much lower threshold, which is a threshold of between 10 to the power of 2 to 10 to the power 4 mils for signifying infection. Now remember that the urine specimen can be obtained in several ways. One way in which you can obtain the urine specimen, the most cleanest way, if I could say, is by a suprapubic aspiration, where you actually feel for the pubic bone just above. You feel for the distended bladder. Of course, you can only do this with a distended bladder. Then you insert your needle and you aspirate the urine from there, and you send that to the culture. That's very sterile. But other than that, you may perform an in and out catheterization, which you can do even in children because the catheters are small, but usually catheters are quite uncomfortable. And you can also do what is known as a midstream clean catch, where the person is actually allowed to urinate. Then midstream, they hold the urine and then urinate in a container. The reason why we do a midstream clean catch is because the first urine is meant to wash out any of the organisms that may be there that may give you a wrong picture, so that you can actually have a good indication of what is affecting this individual. So generally, if you get a suprapubic aspiration or even an in and out catheterization, you need also a lower threshold of 10 to the power of 2 to 10 to the power 4 mils generally, which is going to be indicating an infection. Now, remember that infections can actually recur after antibiotic therapy, and this is due to two main things. It could either be a relapse or it could be a reinfection. Now, what exactly is the difference between the two? Now, remember that the persistence of an originally infecting strain is going to be dependent on the species, the antibiogram, as well as the serotype and the molecular types that are affecting an individual. And pretty much, if someone gets a UTI within, or symptoms of a UTI within 2 weeks of them stopping the treatment, then we consider this as a relapse and not really a reinfection. Then if they get the symptoms or they get reinfected with a new strain after 2 weeks, then we consider that as reinfection. Now remember, when you look at the term acute pyelonephritis, this is just simply a chronic interstitial nephritis where you have this bacterial infection affecting the kidneys, and of course it's going to be manifested by caliciodilatation and even some cortical scarring that you may see. Now, what are some of the definitions that I want you to keep in mind? So the first thing that I want you to keep in mind is bacteriuria. This is just simply bacteria in the urine. So an individual may or may not be symptomatic. If they are symptomatic, then they have a certain number, then you call that as a UTI. If they are asymptomatic, then you have to have a significant number for you to actually consider it as a UTI, or you may actually even consider it as just significant bacteriuria. So if someone has more than 10 to the power 5 colony-forming units per mil in the midstream urine, then we consider them to have a significant bacteriuria. That's assuming that they don't have any symptoms. They're asymptomatic. Now, someone with a UTI just simply has to have significant bacteriuria plus symptoms. I will talk about the symptoms of UTIs very shortly. So someone with 10 to the power 5 colony-forming units per mil, and they have symptoms, you call that as a UTI. You may sometimes have what is known as a complicated UTIs. Rule of thumb is this: if you get a UTI in a male, most likely UTIs in males, especially very young individuals, tend to be complicated UTIs because UTIs are not so common in males, especially very young males. So you may have a UTI with the presence of certain risk factors, which could be renal or urinary tract abnormalities, voiding difficulties, decreased kidney function, indwelling catheters, immunosuppression, or even a virulent organism like a Staphylococcus aureus. You certainly consider that as a complicated UTI. Then there are many definitions for a recurrent UTI, but the one that I've come across that actually makes the most sense and is a common definition among different literatures is pretty much either a reinfection, meaning you get a new organism, or a relapse by the same organism, which is usually within 2 weeks, and you get 2 or 3 of these per year, then you consider this as a recurrent UTI. So if you get 2 or 3 episodes per year, you can call this as a recurrent UTI. You may also have abacterial cystitis, which are symptoms without bacteria. So this is very, very common in women. Now let's go into details of urinary tract infections. So we'll begin with an acute urinary tract infection. Remember that the vast majority of acute symptomatic infections are going to involve women. I'll explain why. And then, of course, the acute symptomatic UTIs are usually uncommon in men that are under the age of 50. Like I said, if you get a UTI in a male that's under the age of 50, you should consider this as a complicated UTI. Then the development of asymptomatic bacteriuria, where you have just significant bacteriuria without any symptoms. This is actually rare in men below the age of 50, but it's common in women between the ages of 20 to 50. This can also even happen in pregnancy. So remember that it is actually much more common in elderly men because the prostate also tends to enlarge, the stasis of urine, so on and so forth. And of course, the incidences are actually high also in women, about 40 to 50%. We can actually think of UTIs epidemiologically. This is just similar to pneumonia, the discussion on pneumonia. So it could be actually community-acquired infections, which are not associated with any catheters, or it could be nosocomial infections, which are associated with catheters. Remember that the longer catheter stays in a patient, the more this patient actually puts themselves at risk of developing a UTI. So what are the causes? So the route of inoculation could include either urethral inoculation or hematogenous spread. So with urethral inoculation, this is where you pretty much have an ascent of bacteria from the bladder, and this may actually follow and is probably even the pathway for most of the renal parenchyma infections, which is just simply ascending from the bladder upwards. And whether the cystitis or the bladder infection actually develops and interacts with the effects of the pathogenicity of the strain, the inoculum size, and the local and the systemic host defenses, this is what's going to be denoting how exactly this person is going to be presenting. Then, of course, you may get some hematogenous spread where it's spreading to the blood. This is very common, especially in debilitated patients who are either chronically ill or have some immunosuppression of some sort. You may get metastatic staphylococcal or even candida infections of the kidney, and these are often going to be following your bacteremia, your fungemia, and it's going to be spreading from a distant focus, for example, from the bone, from the skin, from the vasculature, even anywhere else, causing this pyelonephritis. Now, the pathogens that are implicated include Escherichia coli in 90% of the time, Staphylococcus saprophyticus, which occurs in sexually active women. I want you to keep this in mind. Proteus mirabilis, which is going to be suggesting kidney stones. You may have Enterococcus fecalis, which is going to be seen in prostatitis. You may have Klebsiella, which is usually seen in catheterized patients. I want you to keep in mind on Klebsiella. I want you to keep in mind on staph. I want you to keep in mind on E. coli. I want you to keep in mind on Proteus. Then, of course, you may also have, as a sidebar, not really typically urinary tract infection, but I just wanted to put this here, the sexually transmitted infections, chlamydia and gonorrhea, because they will give you a discharge, especially in males. They will give you a discharge even in females. Now, here are the commonest causing organisms for the community-acquired. E. coli, 80%. You may have Staphylococcus saprophyticus, 10%. Klebsiella pneumonia, 5%. Other organisms. Then, you may sometimes have what is known as an acute urethral syndrome, which is pretty much a sexually transmitted infection. It may be attributed to Neisseria gonorrhea. I'm not talking about sexually transmitted infections here. I'm talking about urinary tract infections. You may have Chlamydia trachomatis, Neisseria gonorrhoeae. You may have your trichomonas, you may have your candida, even your herpes simplex, that may cause symptoms that are similar to a lower urinary tract infection. Sometimes they do also have the propensity to cause your lower urinary tract infections. Then you may also have hospital-acquired or catheter-associated. These are nosocomial infections. E. coli is also 30%, Enterococci, Pseudomonas, Staph aureus, yeasts, and even some Enterobacteriaceae. So what are some of the risk factors? First of all, gender and sexuality. Remember that the female urethra is shorter than the male urethra. So females are very prone because they have a short urethra. That's the first thing. The second thing is because of the proximity of the opening of the urethra to the anus. So if a female actually wipes from the back going to the front, when they are from using the toilet, of course, to go number 2. If you don't know what number 2 is, I'm sorry. To go and defecate. So if they wipe from the front going to the back, then you're wiping from the urethra going to the anus, which is not much of a big deal. But if you wipe from the back going to the front, from the anus going towards the urethra, then you may actually colonize the urethral opening with these bacteria. So pretty much the gram-negative bacilli that are going to be coming from the anus, and of course the length of the urethra is quite short. And that also sexual intercourse can actually cause introduction of the bacteria into the bladder, and actually has been temporarily associated with the onset of cystitis, especially in younger women. And remember that in men below the age of 50 years, unless if there is a history of being homosexual, UTIs are not so common. Unless if they're homosexual. So you should actually question this if you see a UTI and there's no other abnormality in this person. Then, of course, lack of circumcision has been identified as a risk factor for UTIs in both neonates as well as young men. Then remember also that pregnancy also has a very good bearing on causing UTIs in women. So that's why we usually do screen and we do often urinalysis throughout pregnancy to pick up if this woman may have an asymptomatic bacteriuria, or to pick up whether this woman may have UTI. So remember that the smooth muscle function is altered by progesterone. Progesterone is a smooth muscle relaxant. It causes smooth muscle relaxation. Also, during the process of pregnancy and labor, there is a time where there is some bladder catheterization that takes place, and this may actually introduce infections. Now, remember when I was telling you about the toilet seats? And I say that not entirely. Imagine this: if you're sitting on the toilet seat, the only thing that is in contact with the toilet seat are your thighs. And unless if the water splashes on your mucosa, that's where it could be probable, but it's very unlikely, unless if maybe you poop with the force. Anyways, you may also have a vesico-ureteral reflux, which is pretty much reflux of urine from the bladder cavity into the ureters. So this can actually even go back into the renal pelvis. Remember that this may carry some of the organisms backwards. So this occurs especially when someone is voiding, where you get a pressure that is increasing inside the bladder, and the bladder cannot overcome this pressure, and such that this urine backflows into the ureters, and it may even reach the renal pelvis. Now, this is actually common among children with anatomical abnormalities of the urinary tract, and of course, this may even happen in children that have anatomically normal urinary tracts, and this usually disappears with age. Then we may also have vesico-ureteral reflux that may promote the ascending of the infection, like I said, in several different ways, including things like increased delivery of bacteria, increased size of inoculum, even incomplete emptying of the bladder, because you have urine that remains in the bladder, and this provides a nidus for infections to set in. Then you may have other risk factors like obstruction, which may be due to tumors, strictures, stones, prostatic hypertrophy that may result in hydronephrosis, urinary stasis, as well as impaired host defenses that greatly increase the risk of UTIs. Then you may also have a neurogenic bladder where the bladder doesn't contract so well. You may see this in spinal injury, tabes dorsalis, which is seen in syphilis. Then you may have multiple sclerosis, you may have diabetes, and even other diseases. And of course, diabetes may also cause a neurogenic bladder disturbance, and it may also be due to other immune disorders. Then you may have immunological deficiency, especially with those that have a CD4 count less than 200. They are at risk of both bacteriuria as well as symptomatic urinary tract infections. And remember, even the bacterial virulence, if you get a strain that is very virulent, you will definitely be at a higher chance of contracting the urinary tract infection as opposed to someone who doesn't get a virulent strain. So the strains actually differ in virulence. You may also have some genetic factors that have been implicated, but I won't go into detail much of that. So the clinical presentation is that the UTIs could present either as a urethritis, a cystitis, an acute pyelonephritis, or we'll talk about them under the aspect of catheter-associated UTIs. The above three will be pretty much associated with community-acquired UTIs. So I'll talk about the presentations on each and the symptoms that you would expect. So beginning with urethritis, remember that in 30% of the women, they're going to be presenting with acute dysuria, frequency pyuria, and they're going to be having a midstream urine culture that shows either no growth or insignificant bacterial growth. Remember, for it to be significant, more than 10 to the power of 5. Then sometimes you may have chlamydia or gonorrhea. You should suspect this if there's a gradual onset of illness, if there's no hematuria, if there's no suprapubic pain, and if the symptoms are there for more than 7 days. Sometimes they may have a mucopurulent cervical discharge, so you may actually pinpoint that this is actually a sexually transmitted infection. Now, patients that actually have urethritis may have gross hematuria, suprapubic pain, and abrupt onset of illness, and even a duration of illness of less than 3 days. And they may also have a history of UTIs in the past that may actually favor the diagnosis of E. coli being the cause of the UTI. Then you may have a cystitis, which is affecting the bladder. So here they're going to have dysuria, frequency, urgency, suprapubic pain. So I'll just explain these terms. Dysuria is just pretty much difficulty urinating. Frequency is increasing the number of times you urinate in a given instance or in a given day. Urgency is just this sensation of feeling that you need to go and void. Then you may have the urine often being grossly cloudy and even malodorous. It may have blood in 30% of the cases. And like I said, if a genital lesion or vaginal discharge is present, then you should suspect that it may be a urethritis, a vaginitis, a cervicitis that is caused by pretty much your chlamydia trachomatis, your Neisseria gonorrhea, or your trichomonas. Then, of course, consider also other things such as candida, herpes simplex. Then what about acute pyelonephritis? So here the symptoms are going to be developing very rapidly. So they may develop in a few hours, they may develop in a day, and the patient is going to be having systemic symptoms. That's the large difference between this and the lower urinary tract symptoms. Here they may have systemic symptoms. So they may have fever, they may have shaking chills, they may have nausea, they may have vomiting, they may have diarrhea. They may or may not have features of cystitis, and they may, on your physical examination, they may have fever, tachycardia, generalized muscle tenderness. They may even have marked tenderness when you palpate one or even both of the costovertebral angles. So you call this as a deep abdominal palpation, or you may call it as a costovertebral or renal angle tenderness. So in some patients, the signs and symptoms of gram-negative sepsis may actually predominate. What about catheter-associated UTIs? Remember that this affects about 10 to 15% of all catheterized patients in the hospital, and recall that the risk of this person getting an infection actually increases by 3 to 5% each and every single day that a catheter remains in situ. So most catheters actually, catheter-associated infections are going to cause minimal symptoms. There may be no fever, and often they're going to be withdrawing or resolve when the catheter is withdrawn. But in some cases, patients actually do progress into sepsis and they may actually die. So especially with the gram-negative bacteria, these are going to be causing most of the catheter-associated bacteriuria in about 1 to 2% of the cases, and it's actually the most significant recognized complication of catheter-induced UTIs. And the investigations that we're going to be ordering include a urinalysis, which many do not actually consider as an investigation. But if you send it to a lab, doesn't that make it an investigation? So many people actually consider it as a bedside assessment. So pretty much you look for your urine sediments, you comment on the color. It may be, of course, cloudy, it may be malodorous. You look if there are any urine sediments when you're performing your urinalysis. Then, of course, your nitrites as well as your leukocyte esterase will be positive. Then, of course, the leukocytes are going to be found in the urine. So if you have more than 5 white blood cells per high power field, if you have centrifuged the urine, if you have spun the urine in a machine, which is known as a centrifuge, then you just need more than 5. Then if you haven't, then you need more than 10 white blood cells per high power field. This is going to be suggestive of a UTI. Then microscopy is going to be, of course, pointing us towards a single microorganism per oil immersion of unspun urine. That's going to be a colony growth of more than 10 to the power 5 colonies per mil. And I already explained this in the first slide. So remember, you should also send your urine for microscopy, culture, and sensitivity. So this is obviously going to give you the definitive diagnosis, and you're able to grow these things more than 10 to the power 5 colonies. Then if you have less than 10 to the power 5 colony forming units per mil of urine, but you have pyuria, where you have more than 20 white blood cells per mil or per cubic millimeter of urine, then you actually refer to this as sterile pyuria. And the causes of sterile pyuria can include a previously treated UTI, prostatitis, an STI, TB, appendicitis, bladder tumors, stones, polycystic kidney disease, and even drug-induced cystitis. If many different organisms actually isolated, then it's most likely the sample was contaminated, so you'd have to collect another midstream clean catch. Other investigations include a full blood count, which may show an increase in the white blood cell count, UNEs, creatinine, as well as C-reactive protein, blood cultures, which may be needed for pyelonephritis, blood glucose to, of course, rule out diabetes, because you have a lot of these recurrent UTIs with diabetes. Then, of course, you may also do some radiological, urological examinations or investigations to, of course, look out for any predisposing conditions such as urolithiasis, which is urinary stones, BPH, and even vesical ureteral reflux. Then you may do a kidney ultrasound, which may show you if there's any obstruction or hydronephrosis. You may do a post-void bladder ultrasound. You may do a kidney, ureter, and bladder x-ray. You may pick up the radiopec stones on this. You may also do an intravenous nephrogram. Now, the management, remember that except in acute uncomplicated cystitis in women, you need a quantitative urine culture, and a rapid diagnostic test should be performed for you to confirm infection before you start them on treatment. The bulk majority of the other patients, we do start them on treatment. So factors that may actually predispose the infection, such as obstruction, calculi, you should identify these things and remove them. We should relieve the clinical symptoms that this person has, but them having their symptoms relieved doesn't mean that they are bacteriologically cured. Remember, we talked about relapse? So they could relapse. So they should take the medication until the stipulated time. Then in general, the uncomplicated infections are usually confined to the lower urinary tract and respond to short courses of therapy, while as the upper urinary tract usually require much longer treatment. I would divide them into groups. So what's our admission criteria in a patient that comes in with acute pyelonephritis? Number one, if they have inability to maintain oral hydration or take medication, if there's concerns about compliancy, if you're uncertain about the diagnosis, and if there are even some severe illnesses with high fevers, pain, and even marked debility. Now, what's our management? So paracetamol or NSAIDs plus or minus to relieve the symptoms. We remove the catheter if it's present, and we may cover them on empirical antibiotics. Generally, your fluoroquinolones and your aminoglycosides are going to be achieving higher tissue levels, and so these are actually the preferred drug of choice. Then you may also have ampicillin and sulfonamide that should not be used as empirical treatment because these have developed resistance. And remember that these resistance patterns actually change over time. So what I may teach you in this lecture may not actually even become relevant 2 years down the line. Hell, even this same very year, the drugs that we use here could change. So that's always a moving thing, a dynamic thing. So all pregnant women should be screened for bacteriuria in the first trimester, and they should be treated if they have bacteriuria. So IV medication should be changed to oral medication as soon as the patient can swallow orally. Then when the patient becomes afebrile, we can actually give them oral trimethoprim and sulfamethoxazole, which is Septrin, or ciprofloxacin or norfloxacin for about 10 to 21 days. Then parenteral therapy is actually indicated for hospitalized patients. Aminoglycosides, about 3 to 5 milligrams per kg once a day, is actually quite cost effective and actually is associated with low toxicity when we use it in a shorter duration because these drugs are nephrotoxic, so we want to use them for a long time. They may actually provide a therapeutic advantage compared with the beta-lactamase. The beta-lactams, your penicillins, because they have marked and even sustained concentrations in the renal tissue. That's why they're nephrotoxic. Then there is also something about cranberry juice that I was reading the other night, that it actually does decrease the frequency of UTI onset in certain groups and certain individuals, though there's a bit of some controversy concerning the literature. Some people say it hasn't yet been researched to that extent, and I read a meta-review analysis that actually say that it actually does reduce the frequency of UTIs occurring in an individual. So I would actually advise it for my patients that they should get a lot of cranberry juice and they should hydrate, a lot of hydration. So what are the antibiotics that we're going to be using? So if they have an acute uncomplicated lower UTI in a woman, we can use nitrofurantoin if their estimated glomerular filtration rate is greater than 45, or if they have no history of kidney injury. Then we may use trimethoprim sulfamethoxazole 480 milligrams, 2 tablets, orally twice a day for 3 to 5 days. Norfloxacin 400 milligrams orally twice a day, or ciprofloxacin 500 milligrams orally twice a day for 5 to 7 days. This is a very common regimen. Then with acute uncomplicated pyelonephritis in women, remember this is caused by E. coli, Proteus mirabilis, and even Staphylococcus saprophyticus. So your norfloxacin 400 milligrams orally twice a day, or your ciprofloxacin 500 milligrams orally twice a day for 7 to 14 days. Or even just a single dose of ceftriaxone 1 gram or gentamicin 80 milligrams IV, followed by your trimethoprim and sulfamethoxazole for 80 milligrams, 2 tablets, orally twice a day for 14 days. Now, for the complicated UTIs in men and in women, remember that the common agents are Escherichia coli, Proteus, Klebsiella, Pseudomonas, Serratia, Enterococci, Staphylococci. These are common etiologies. So it may depend on whether it's mild to moderate illness, but generally if there's no nausea, if there's no vomiting, we can treat them as an outpatient. We may actually give them norfloxacin 400 milligrams orally twice a day, or ciprofloxacin 500 milligrams twice a day orally for 7 to 14 days. If there is severe illness or there's a possibility that they may go into urosepsis, then you want to admit them and give them intravenous antibiotics, your ceftriaxone 1 gram IV twice a day, gentamicin 80 milligrams IV TDS, and or ampicillin 1 gram IV 4 times a day, then 500 milligrams IV 4 times a day. Then, of course, your IV quinolones such as ciprofloxacin 200 to 400 milligrams IV twice a day can also be used as alternatives. Then, of course, if Enterococcus is being suspected, then you base this based upon the gram staining, then you may use your ampicillin 1 to 2 grams IV 6 hourly plus your gentamicin 1 milligram per kg 8 hourly, or adjust for the renal function. Now remember that the whole key for this thing is to get your sensitivity reports and see what this patient responds to. Then what are the complications and prognosis? The infection can spread upwards and cause a pyelonephritis. You may result in a perinephric or even an intrarenal abscess. These have to be drained. And of course, they may complicate into other things. You may have prostatitis, sepsis, and then of course in the kidney, they may have acute kidney injury, hydronephrosis that may happen with the dilatation that you may see on your ultrasound. Then of course you may have recurrency. 1 in 3 women usually have reinfection with a new pathogen. Then of course the prognosis, usually the symptoms are going to be resolving in 3 to 4 days. Remember that this does not mean that you have bacteriologically cured, but this is only guaranteed when you have effective antibiotic treatment. And then if you don't have antibiotic treatment, 5 to 7 days without treatment or with a resistant organism. Now, coming back to our warm-up question, the typical features of lower urinary tract infections include A, rigors, loin pain, and renal impairment. So these are features of upper urinary, not respiratory. So that's false. B, suprapubic pain, dysuria, and hematuria. These are features of lower urinary tract infections. C, progression to acute pyelonephritis if untreated. Yes, it may progress. Then, of course, the midstream clean culture of Escherichia coli greater than that. That is true. And the drug of choice for the majority is ciprofloxacin. Not always. It's not always the drug of choice. I really hope you enjoyed learning about UTIs. If you did, consider subscribing to the channel. Hit the bell notification icon to be receiving notifications of such videos every time I post. Tell a friend to tell a friend that we are back doing lectures on the channel to Zambia and beyond. My name is Dr. Moses Kazevu. Until next time, bye-bye.